because of its sawtooth appearance. The P wave will have like ano siya, marami siyang humps before a QRS complex. That's a flutter. This is different from atrial fibrillation because delineable yung P wave. Malalaki siya, para siyang chocolate hills. Yung ventricular fibrillations kasi, anong tawag namin, fibrillatory waves lang. So irregular siya, maliliit na irregular. Okay, ito, klarong-klarong may P-wave. Kaso lang, ang dami-dami naman. So kung titingnan mo, 1, 2, 3, 1 QRS, 1, 2, 3, 1 QRS. So dito parang 3:1, then ito 2:1, dito 5:1. So most of the time, atrial flutter is regular, and that's why nandoon siya sa narrow complex regular tachycardia. Sinus tachycardia, SVT, atrial flutter, differential diagnosis, but sometimes an atrial flutter can be irregular. However, it's still easy to diagnose because of a sawtooth appearance of the P waves. Okay? So, we will now go back to the differential diagnosis of patients with narrow complex tachycardia but with irregular rhythm. There are only two: multifocal atrial tachycardia and an atrial fibrillation. So, from a multifocal atrial tachycardia, from the term itself, multifocal, ibig sabihin, there are a lot of focus, or there are different cells in the atrium, either right or left, that is firing at a faster rate than SE node and is able to conduct to the ventricles. So, kunwari, eto siya, pumasok siya, then it produced this QRS complex. Then ito, this atrial cell has fired and then able to conduct to the ventricles and nagproduce siya nito. Kaya, nagkakaroon ka ng iba-ibang morphology ng P-wave. So the definition of a multifocal atrial tachycardia is a narrow complex tachycardia with irregular rhythm, but there must be 3 or more different P-waves. Kaya nga multifocal. Atrial, meaning galing sa atrium. Multifocal, meaning iba-iba ang origin ng impulse, and that is the reason why the P wave has a different morphology. So, for example, itong P wave na to, that's morphology, probably galing sa SE node to. But tingnan mo yung P wave na to, it's a little bit smaller, narrower as compared to this one. Ito, same siguro sa first beat. Same pa rin sa first beat. This is a little bit different. Maybe same as ito. But look at this one, it's now inverted. So we have 3 na, and then this is tachycardic and it's irregular rhythm. Then this is multifocal atrial tachycardia. This cannot be an SVT because an SVT is regular narrow complex without a P wave. This cannot be a sinus tachycardia because there is, although there's a PQRS in every beat, but it's irregular, okay? So for a multifocal atrial tachycardia to have a diagnosis of this multifocal atrial tachycardia, you must have 3 different P-wave morphologies, and it's an irregularly occurring narrow complex QRS. Okay? So skip tayo dyan. Ayan, sorry, meron pa pala akong maraming example ng atrial flutter. Look at that, you have to have memory of atrial flutter. Kasi ganyan yung mga ngipin ng mga shark and then QRS. So ito, regular siya dito. So this is, if I have to count like 3 is to, sabihin na natin 4 is to 1. Kasi isasama ko to. So 4 is to 1. Okay. Yes. So this is irregular. And this is another differential diagnosis of a patient with irregular narrow complex QRS. This time, hindi mo na ma-delineate ng maayos ang P wave. So it's irregularly occurring and that the QRS complex is narrow, but the P wave is not delineable. Hindi katulad sa multifocal atrial tachycardia na klarong-klaro yung P wave. Nagkakaroon ka lang ng tatlong morphology. Sa atrial fibrillation, halos wala talaga. So, eto, don't be confused about this one kasi once lang naman siya. Tsaka pangit naman ng morphology ng QRS. Siguro lang may nag-try na malaking atrial cell, no? I mean, a bigger impulse, kaya it produced a bigger P wave, but most of the time, walang delineable P wave. So that's atrial fibrillation. So if you cannot differentiate a P wave, a delineable P wave, then diagnose as atrial fibrillation. So to differentiate between a multifocal atrial tachycardia versus an atrial fibrillation, there must be a narrow complex QRS, and both must be tachycardic and both must be irregular. But madi-differentiate mo lang yung dalawa because in multifocal, there are delineable P waves. Kaso nga lang, nakakakita ka ng tatlong different P waves. In atrial flutter, atrial fibrillation, halos walang P wave talaga. Or kung meron man, hindi siya klarong P wave. Okay, that's atrial fibrillation. So if you ask me, on clinical practice, I would rather manage as atrial fibrillation because mas common ang atrial fibrillation and less yung multifocal atrial tachycardia. So if you are given an exam, if you are going to answer an irregular rhythm, irregular rhythm, na narrow complex QRS, tas hindi ka sure, mas mabuti lang isagot mong atrial fibrillation rather than a multifocal atrial flutter, atrial tachycardia. So you will answer multifocal atrial tachycardia if sure ka, meaning nakakita ka ng tatlong morphology ng P wave. Pag hindi ka sure, mag-atrial fibrillation ka na. It's a hint. Okay? So, ang atrial fibrillation, there is no discernible P waves. It has an irregular rhythm. And the cause is an atrial cell that has been infarcted, and it produced electrical impulse. And this electrical impulse naghiwa-hiwalay into what we call as wavelets. Parang kung among students siguro, imagine nyo lang merong isang firecracker tapos boom, nag-separate siya. And then that wavelets conducted to the ventricles and enough to produce a ventricular conduction. So, kaya meron kang tinatawag na fibrillatory waves, mga less than 1 millivolts lang ng movement ng atrium and then a QRS complex. Kaya tinatawag namin siyang atrial fibrillation. Minsan it's coarse, meaning a little bit bigger, parang ganito. Kasi may baka naman malaki-laki lang ng konti. Ito, this is a P wave. I think baka nag-conduct dito yung SE node. Kasi sometimes nakakapag-conduct naman si SE node. Parang ganito. But most of the time, walang discernible P waves. We just call it either a coarse or a fine fibrillatory waves. So if we cannot diagnose as sinus tachycardia kahit may P wave because irregular. If you argue that this is a multifocal atrial tachycardia, okay lang din if you can show me like 3 morphology of a P wave. Minsan nag-argue mga cardiologists if it's an atrial fibrillation or a multifocal atrial tachycardia, it doesn't matter because the management will be the same. So, ang mag-differentiate na lang yan kung sino ang totoo is during an electrophysiologic study. Dadalhin mo yung pasyente sa cath lab, doon makikita mo kung meron talagang fibrillation or different P waves. Okay. So, this is an example of a narrow complex tachycardia. It's irregularly occurring. Dapat at this point in time, yung mata nyo magaling nang mag-identify ng irregular rhythm. Without using a caliper, without using a bond paper, mata pa lang, alam nyo nang irregular siya. So, this is wide here, and this is narrow here, so that's irregular. And the P waves are just, of course, fibrillatory waves, so this is an atrial fibrillation. All right? So an atrial fibrillation can be fast. We call it controlled ventricular, rapid ventricular response. An atrial fibrillation can sometimes be between a heart rate of 6 to 100. So we call it atrial fibrillation with controlled ventricular response. But an atrial fibrillation can also have a slow heart rate, like 50 beats per minute. So we call it atrial fibrillation with a slow ventricular response. But in all cases, there is a narrow complex QRS, and then the rhythm is irregular, and that there is no discernible P waves. Okay, most of the time we put atrial fibrillation on a tachycardia algorithm because dun siya it causes more of a hemodynamic compromise rather than if it's in a controlled or slow ventricular response. So this is an example of atrial fibrillation with slow ventricular response. Sobrang hina niya ng heartbeat, but it's irregularly irregular and that there is no discernible P wave. Okay. Another example of an, if you look at this is an irregularly irregular occurring QRS complex, and it's narrow, and that there is no discernible P wave. So we will diagnose as atrial fibrillation. So kung irregular ang rhythm, again, tas hindi kayo sure kung multifocal or atrial fibrillation, ang isagot nyo na lang atrial fibrillation. By 80% correct kayo. Okay? So we will now go to ventricular tachycardia. This is on the right side of the algorithm. Ito yung wide complex tachycardia, but with a tama, yun na yun. Wide complex siya, tachycardia. So ganyan yung itsura niya. So here, sinus tachycardia siya, parang meron siyang first degree AV block. No? And then biglang nag-ventricular tachycardia siya. Okay? So na wide complex tachycardia is ventricular tachycardia. If hindi nyo na papansinin yung SVT with aberrancy, ito sure na akong VTAC to because narrow complex siya from the start. Pero kung nakita ko yung wide complex siya before siya nag-tachycardia, then I'm confident that it's SVT with aberrancy. But dito kasi, narrow complex QRS siya, and then biglang nag-tachycardia, so it becomes a wide complex tachycardia. We call it ventricular tachycardia. Okay? Okay, so then how you see a wide complex tachycardia. So halos wala ng P wave, no? Because the origin of the impulse is coming from the ventricles. There must have been an infarct in the ventricles that has fired and able to conduct the ventricles. It has override the SA node, and kaya wala ng P wave. Puro na lang siyang QRS complex na sobrang bilis. And yan, ventricular tachycardia. So most of the time, the ventricular tachycardia is regular. Hindi siya nagiging irregular because ano naman yung atrial cell na infarcted is firing constantly, and it will override the SA node. Kaya kung palagi na siya, so magiging regular yung rhythm niya na wide complex QRS. Okay. So there are different terms in ventricular tachycardia. So we say it's a sustained pag nag-wide complex QRS tachycardia siya, but less than 30 seconds lang, and then nag-convert back to sinus rhythm. So we call it non-sustained. Pag more than 30 seconds naman yung diretso talaga yung ventricular tachycardia, we call it sustained ventricular tachycardia. Sometimes we differentiate it into either monomorphic or polymorphic. Ibig sabihin, pag monomorphic, same yung itsura. Ibig sabihin yan, the origin of the impulse is coming from one area only. But if it's a more polymorphic, ibig sabihin, the origin of the impulse is nag-change. Maraming infarcted cells na mabibilis, faster than the firing rate of the SA node. So it has override the SA node. So itong area muna. And then the other ventricular cell now fired at a faster rate, faster than the first ventricular infarcted cell. So siya naman ang mag-override ng impulse, and that's why nag-change yung morphology. So polymorphic ventricular tachycardia. In this example, magiging irregular na yung rhythm niya kasi magkaiba-iba yung origin ng infarcted cell. So if you see monomorphic versus a polymorphic, malalaman mo mas somehow, pares naman sila toxic, pero mas pangit si polymorphic kasi maraming infarcted cell. Torsade point is different, and it might be difficult at your stage as first year. This is parang lumiliit na lumalaki. Para siyang polymorphic, pero ano siya, para siyang umiikot na lumiliit and then lumalaki. So this is another form of ventricular tachycardia. But the problem here is iba naman yung cause ng ng origin ng impulse niya. So, I will not give you an example, a question, an exam about their study point because it's difficult at your stage. So, ventricular tachycardia lang, you don't need to answer monomorphic, polymorphic, sustained, or non-sustained. Ventricular tachycardia in an exam is already enough to me. So as long as it's a wide complex QRS tachycardia, then you diagnose as ventricular tachycardia, not SVT with aberrancy. Parang irregularly irregular, narrow complex, ang isasagot yung atrial fibrillation rather than multifocal atrial tachycardia, most likely you will be correct. Okay. So, yes. So this time, there are just like fibrillatory waves. Ito yung opposite kay atrial fibrillation. Because in atrial fibrillation, the origin of the impulse is coming from an infarcted atrial cell. But here, it's an infarcted ventricular cell that has produced an electrical impulse. And ang difference ng ventricular fibrillation to a ventricular tachycardia is in ventricular tachycardia, medyo malaki yung the electrical impulse has produced an organized ventricular contraction na 1 beat. Ito, in ventricular fibrillation, kasi maliliit lang yung impulse, not enough to cause the entire ventricular muscle to contract. Parang anterior wall lang, and then next is lateral wall, then next inferior wall. Not habang nag-contract si anterior wall, the rest of the ventricular walls are in a relaxed state. And so, yung nag-contract lang anterior wall, it will not be enough to eject enough stroke volume. So, talagang tawag namin yan is deadly. The patient will die because there is no enough stroke volume produced. So, ventricular fibrillation siya. So, ang malalaman mo siya because it's irregularly irregular, and then there is, hindi siya minsan narrow, minsan wide, pero sobrang chaotic yung impulse niya. That's ventricular fibrillation. Unlike ventricular tachycardia, it's an organized QRS complex na malalaki, and then talagang ma-appreciate mo that there is a QRS complex. Ito, halos pangit na, chaotic ventricular contraction. So, can be coarse, but it can be fine. However, there is no P wave, there is no true QRS complex, and the rhythm is irregular. That's ventricular fibrillation. Okay? So, what you do in a ventricular fibrillation is you have to defibrillate the patient, meaning to say, kailangan mong kunin yung defibrillator and then you shock the patient at 200 joules. Ang gusto mong mangyari is you just want to shock all the ventricles and then para mag-relax sila lahat, and then merong isang somehow a pacemaker that would initiate an electrical impulse and be able to conduct to the ventricles. Yun yung dasal mo. That's the purpose of doing a ventricular a defibrillation. So you want to electrically stimulate all the muscles para lahat sila relax sabay-sabay. Kasi sa ventricular fibrillation, hindi nagsasabay-sabay. Yung iba contracted, yung iba relax. Kaya hindi ka nakaka-produce ng, in order to produce a good stroke volume, dapat sabay-sabay lahat mag-contract, mag-inject ng blood. Pero in ventricular fibrillation, ano sila? Hindi sila sabay-sabay. So, you want to electrocute the ventricles para relax lahat, and then merong isang mag-conduct ng impulse and then be able to cause a good ventricular contraction. Okay, so we are done with tachycardia algorithm. If it's fast, meaning heart rate more than 100 beats per minute, and there is a wide complex QRS, ang sagot nyo is isa lang, ventricular tachycardia. Now, it's narrow, you have to look at the R2R interval if it's either regular or irregular. If it's irregular, if it's regular and there's a P wave, sagot nyo is sinus tachycardia. If there is no P wave, SVT. Ang hirap naman kasi ni atrial flutter kung saan natin siya ilalagay, no? Kasi sa atrial flutter, hindi ko siya minsan sinasama because hindi mo na kailangan ng ibang algorithm for atrial flutter. Makikita mo talaga siyang ano, klaro na atrial flutter siya. Madali lang siya ma-diagnose. Now, if it's irregularly irregular, and that there is a P wave with three different morphologies, that's a MUT or multifocal atrial tachycardia. And if there is no P wave, that's an atrial fibrillation. So if it's a flutter waves, kasi sometimes regular siya, sometimes irregular siya, that's atrial flutter. But most of the time, an atrial flutter is regular. Okay? Yay! My question before we go to review, do you have any question?
Dok, tulilipat ako kuan, Dok. VTAC ngan fibrillation.
Oo. Ang Vita kasi malaki yung QRS. So if we say QRS, let's say it will be bihira ang ventricular fibrillation to cause a QRS that is like more than 5 millivolts or 5 small squares. Ang ventricular tachycardia, makikita mo siyang malalaki siya. So it will give you a hint na ventricular tachycardia. Ang ventricular fibrillation kasi 1 to 2 millivolts lang yun. Small QRS complex. And it will always be irregular. Para siyang atrial fibrillation, irregular. So that's ventricular fibrillation. Tapos, paano pa ba? Mas toxic si ventricular fibrillation. Talagang walang pulso if you go clinically. Pero kung ECG lang binabasa mo, there's no other way to help you. You just have to have a photographic memory of ventricular fibrillation. The definition is there. Now it's just a fibrillatory waves. There's no delineable QRS complex, no P wave, and it's irregularly irregular. It's so fast, like more than 200 beats per minute. Ventricular fibrillation. While a ventricular tachycardia is a regularly occurring wide complex QRS. Hindi ko alam kung nakapulong yun. Wala nang iba eh. What else? May tanong pa ba kayo? Ano yun? Yes, Winston, go. Okay. In atrial flutter, the QRS complex in both atrial flutter or fibrillation is the same. I mean, discernible in QRS complex. But the P wave should be discernible, meaning to say the P wave should appear in all leads. Na sawtooth appearance siya in V1, V2, V3, V4, V5, V6, lead 1, 2, 3, AVF. Ganon. Ang atrial fibrillation, minsan sa V1, makikita mong core siya, klaro. Pero dun sa ibang leads, wala. Sabihin, flutter yon, hindi yun. Ano yun? Pag makita mo siya sa V1, pero wala siya sa iba, fibrillation yon. Hindi. Kasi ang flutter, kita siya sa lahat ng leads. Kasi klarong-klarong malaki origin. And then, ang origin ng impulse in atrial flutter is coming from an atrial cell circulating and then nagkakandak sa ventricles. Ang atrial fibrillation is an atrial cell na infarcted na nag-fire ng electrical impulse and then naghiwa-hiwalay, we call it wavelets, paano bang kakalimutan ko ang term? Basta nag-spread yung electrical impulse na nag-spread and nag-form siya ng wavelets and then yung mga wavelets na yun, yung somehow nakakakandak doon sa kaya siya irregular occurring. Okay. Yes. Okay. Yes, ang VTAC is wide complex. Yun lang ang difference niya. Kaya nga, pwede kang magkaroon ng SVT na with wide complex QRS, yung tinatawag namin SVT with aberrancy, meaning RBBB na siya from the start, kaya wide complex QRS siya. Tapos nag-SVT siya, di ba wala na yung P-wave, pero wide complex QRS. It would appear like a VTAC. will be hard for you. If you are in the emergency room and you see a wide complex QRS complex, a wide complex, VTAC agad, huwag ka nang ano, is VT with aberrancy or VTAC? Huwag ka nang mag-isip. In the guideline says na you manage as VTAC. And pakala na si Batman after na ano mo si patient na stabilize mo, nabigyan mo let's say ng amiodarone or you have cardiovert the patient and then nag-sinus rhythm siya. Tapos wide complex pala siya, sinus rhythm na may RBBB. So kanina, SVT with aberrancy. It doesn't matter because the management of SVT with aberrancy and VTAC is the same. So the management, let me review. If the blood pressure is stable, medication lang, you give amiodarone. If the blood pressure is decreased less than 100 millimeters mercury, you have to cardiovert. But if the patient has no pulse anymore, hindi syempre walang BP na yun, you have to defibrillate. So, what's the difference between, hindi ko to kasama ha, pero it's in the book, it's in the chapter in Guyton for this lecture. Pero hindi ko siya isasama sa exam. Kasi feeling ko, hindi pa siya time para sa mga first year for this question. So the difference between cardioversion versus defibrillation, ang cardioversion, yung pag-fire ng machine of pag-electrocute ng machine, it will be synchronized on the QRS. Kasi pag doon siya mag-fire ng electrical impulse sa absolute refractory period, or I mean sa relative refractory period, it will cause ventricular fibrillation. So ayaw natin maging ventricular fibrillation patient kasi VTAC pa lang siya. Mas better kasi yung VTAC than ventricular fibrillation. So kaya synchronized siya. Meaning kahit pag-press ni nurse or ni doctor was at the relative refractory period, the machine will wait to the next beat on the QRS complex and deliver the electrical impulse. Si machine ang nagdi-determine. Kaya nga meron yang, kung maalalaman nyo, meron siyang toot, 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 merong may tunog and then meron siyang arrow na doon siya magpa-fire sa QRS. Now, defibrillation is another form of electrocuting the patient na it doesn't matter what time. Kasi ang ventricular fibrillation, walang QRS complex na yun. So, it doesn't matter anymore. The machine will just fire. By the time na nag-press yung doctor or yung nurse, the electrical impulse will automatically be delivered by the machine. Okay, that's the difference between defibrillation or synchronized cardioversion. So, another point is if the patient is in ventricular fibrillation, if you are doing CPR, the purpose of your CPR is just to keep the patient on ventricular fibrillation. Kasi later, pag maging asystole siya, mamamatay na yon. Huwag niyong isipin na ang pagsi-CPR mo will convert the patient to a sinus rhythm. No. Kaya, pinapalitan namin yung notion or yung understanding ng mga students na mag-CPR lang tayo, huwag tayong mag-defibrillate kasi natatakot tayo or hindi namin alam mag-defibrillate. So CPR lang sila ng CPR. Talagang after 30 minutes or mapagod kayo, mamamatay yung patient because you have not done anything to convert the patient back to sinus rhythm. So CPR will only keep the patient on ventricular fibrillation. So sinasabi lang namin, perform CPR hanggang dumating ako because I want you to keep the patient on ventricular fibrillation. And then pagdating ko, saka ko magdi-defibrillate. Or merong dumating na resident or someone with better knowledge than you to defibrillate the patient. Or ikaw, magkaroon ka ng courage na mag-defibrillate ng patient. Naintindihan niyo ba yun? Kasi ang CPR, it will not convert to a better rhythm. Palagi lang siyang ventricular fibrillation. Alam niyo ba yun or hindi? Anyway, question? I like questions, really, kasi parang feeling ko, dun kayo mas matututo pag may question. Anyway, if you have more questions, pwede pa later. Let's try to review. Okay. Ay, yan. What's that? Kabayang bundat.
Kuan, Doc. Ventricular fibrillation.
I agree with you. Hindi ko siya masasabing VTAC kasi hindi siya ano no, hindi siya like siguro dito kung diretso siya no, ito. Pero hindi naman siya pare-parehas lahat eh. You can argue, polymorphic ba siya? Para sa akin, hindi rin. Kasi, ano siya eh, irregular, tas halos chaotic yung ventricular contraction niya. Ventricular fibrillation. So you have to defibrillate the patient. You can do CPR habang wala pang machine just to keep the patient on ventricular fibrillation para hindi siya mag-convert to asystole. But you still have to defibrillate the patient. If nobody will defibrillate the patient, just pray so hard na somehow mabuhay yung pasyente. Pero most of the time, your success rate will be like less than 20%. Kaya you have to defibrillate the patient. If you defibrillate your patient, your success rate will go up as much as 40%. Kaya the patient will survive. Okay. So, ito yung defibrillation or meron kang pipindutin niya na pang synchronized cardioversion, kaya magiging synchronized na siya, but this is how you do it. Pinakita ko lang sa inyo because para malaman nyo lang na meron kaming machine to defibrillate or cardiovert. So either cardioversion or defibrillation, same machine lang, may pinipindot lang kaming synchronized cardioversion. Pag hindi mo pindutin yung synchronized cardioversion, automatic defibrillation yun. So, okay. What is this?
Systole.
No, pero hindi ito lalabas sa exam.
Oh, grabe daw.
Siya kasi yung pinakamadali.
Bonus, Doc.
Labas mo yan.
Hindi lalabas. So you have to make sure na it's connected to the machine because baka naman hindi lang siya connected. Yung pasyente mo gising na gising kasi si CPR mo. Wag ha. To make sure it's connected to the machine. Otherwise, then it's systole. When you have to do CPR, you will not defibrillate the patient because studies have shown that there's no benefit of sayang lang yung electrical impulse at saka yung kuryente.
Epianay.
Yes, CPR lang at saka epinephrine, then pray na mag-defibrillate, mag-ventricular fibrillation siya or somehow a better impulse. I forgot to say last time, once the patient is in a systole or any tapos nagkaroon siya ng electrical impulse, either junctional or PAC or whatever, as long as there's no pulse, we call it pulseless electromobility. Yes, PEA. Basta walang pulso, kahit junctional rhythm or idioventricular rhythm or sinus bradycardia yung nag-a-appear, pero walang pulso yung pasyente, that's a pulseless electrical activity. You still have to do CPR and then do epinephrine. Give epinephrine. Okay. What's that? Blurred? Sorry.
Supraventricular tachycardia, Doc. No
Yeah.
P-wave.
Ang galing mo. I'm happy. Di ba parang madali lang siguro yung iba nahihirapan, but you are correct. There's no P-wave and it's a fast heart rate. It's narrow complex QRS. So this must be an SVT. Okay? How about that one? Takot kayo? Di pa tayo,
Doc.
diba? Regularly irregular narrow complex QRS, we have only two differential diagnoses, MAT and AF. So you decide.
Atrial.
Oh, then if your answer is atrial fibrillation, you have increased your probability to be correct by 80%. So you will only answer MAT. You will answer MAT if you are so sure that there are 3 or more P waves. So in this particular case, some can argue that it can be MAT because they can see P waves. But if your answer is atrial fibrillation, I will accept that. And my answer is also atrial fibrillation. Yay. How about that one?
Doc, flutter.
Among students, pag madali yung question, 80 to 90% of the class will be able to get a correct answer. So, ikaw dapat makakorek ka. Kasi kung nakaka-correct lahat, tas wrong ka, Tapos dun sa mahirap na question, wrong lahat. Wrong ka pa rin. Yung beauty mo. So, kailangan pag easy question, masasagot mo. Okay? So this is atrial flutter. No more explanation. You can see the morphology of the P-wave as sawtooth appearance. Siya yung pinakamadali. And that's why pag lumabas sa exam ang atrial flutter, dapat hindi ka magkakamali because 80 to 90% of the class will be able to get that. Okay? Yay! Eto.
This is Brady, Doc.
Brady.
You are correct, Brady. But what is the rhythm? Is it-
First degree.
Galing! Galing ni Romeo Bargamento. You are correct. This is sinus bradycardia with first degree AV block.
Oh, okay. I see.
3 AV block. Okay yon.
Long
One
PR interval.
Yes. Pero kung ang sagot mo sinus bradycardia lang, 0.5. 0.5 lang. Mas tatanggapin ko ang first degree AV block here. The cause of the bradycardia here is the first degree AV block. How about this one?
Third degree AV block.
Try harder.
Second degree, Doc. Morbits 2.
Morbits.
Morbits 2.
It's 2.
Mabits to.
And yung
Morbits 2 ngayon.
is the same in all beat. Try to look harder. Are all yes.
Ay, type 1. Sorry.
Morbits type 1.
Narinig na namin, kuya. So this is a P-wave without a QRS. So that's a drop beat. Sana sa exam may arrow, no? Para kasi kung may arrow, madadirect yung mata mo doon. So it's if you see a P-wave without a QRS complex, it is a drop beat. You have to commit. If it's a drop beat, ang sabi, ang turo ko sa inyo, you look at the PR interval before the drop beat and the PR interval after the drop beat. If they are the same, move it's 2. If not the same, move it's 1. Okay? Kung ayaw mo sa technique na tinuturo ko, you have to look at all the beat, lahat ng PR interval in all the beat before you commit if it's either first or type 2, type 1 or type 2. Type 1, iba-iba ang PR interval, nag-iiba-iba, and then type 2, fixed ang PR interval before the drop beat. So again, in type 1, the longest PR interval is before the drop beat, and the narrowest or shortest PR interval is after the drop beat. Okay? Eto.
Brady.
Yes.
YQRS.
Yes.
With P-wave.
Yes.
Agonal rhythm.
Third block. Third
Ah.
AV block.
Area third block.
Mamatay na yun.
Idioventricular.
Ano daw? Sorry, mahina yung signal mo, Mare. This is third degree AV block. Paano ba? Kasi ang hint mo sa third degree AV block is the PR interval in all leads is magkaiba-iba. Mas makikita mong regularly occurring yung PR, yung P waves.
1, 2, 3.
Tapos, yung QRS mo, same din. Pero, dissociated sila. Mahirap ang third degree AV block. So, for example, if we follow our concept, this is a P wave without a QRS complex. We will look at the PR interval before the beat and after the beat. Hindi siya nagpa-follow. Para siyang sasabihin nating type 1, Mobits 1. Pero di ba sa Mobits 1, the PR interval before the drop beat should be the longest. And after should be the shortest. Pero dito baliktad siya, no? Nakuha niyo ba? Kaya hindi siya type 1. Hindi rin naman siya type 2 kasi magkaiba-iba yung ano niya yung PR interval. May mahaba, may maikli. Nakuha niyo ba? Nag-gets niyo ba yung point ko?
Yes, Doc.
Yes, sir.
Alright. Sige. How about this one? Look at the PR interval. Kung pare-pareha sila,
First
you
degree.
check for a P wave with QRS,
Multifocal.
that's a drop beat. Ang multifocal atrial tachycardia is in a fast heart rate. This is a bradycardia. This is in a bradycardia algorithm. So, third degree AV block din to. No? Mahirap ang third degree AV block, no? Kasi for example, this is a PV without a QRS complex. If you look at the PR here, and walang PR here, no, hindi siya first, second, type 1 or type 2. Hindi siya nagpa-follow.
Pero P to P doc nga kuan interval is the same, di ba?
Yes, the same. Yung
Ay.
P to P is the same and R to R is the same, so it's a third degree AV block. Dissociated sila. So it's a
Okay.
third degree AV block. Hindi siya, I was just trying to use the concept of diagnosing a second degree AV block type 1. Hindi siya papasok eh. Okay. Yeah. How about this one?
Kuan ni doc junctional rhythm,
Yes, it's junctional because there is no
inverted P wave.
or inverted P wave lang and then narrow complex pericardia junctional rhythm. Ito,
Idioventricular.
it is idioventricular rhythm. It's a wide complex QRS, na bradycardic, and then no ventricular rhythm. What if this is tachycardic, like 180 beats per minute? Ang diagnosis niyo?
Vita.
VTAP doc.
Right. You are correct. So, si junctional rhythm, if it's also fast, let's say 170 beats per minute, anong diagnosis niyo?
Inverted P.
Accelerated junctional rhythm.
Hindi. 180 eh. SVT.
SVT doc.
Kita nyo na, may mga opposite, sila, junctional rhythm is in atrium, opposite to that sa ventricles. Hindi pala. Atrium din yung yung atrium din yung SVT. Pero siya yung opposite ng junctional rhythm kasi sa junctional rhythm is bradycardic. Pag sobrang bilis na niya, mga 170 beats per minute, it would appear as narrow complex tachycardia without a P wave. SVT yun. Na-gets nyo?
Yes doc.
Okay. Ang atrial fibrillation naman, ang opposite sa ventricle is ventricular fibrillation. Okay. Tapos na. Any question? The room is open for questions, clarifications. In the exam, you will have 10 ECG that you will have to identify. So, nabawasan na yun kasi walang asystole.
I-include good asystole doc.
Di daw pwede. Sobrang dali. Questions? Ay, baka may questions dito sa chat box. Yung iba nagsasagot sa chat box. Sorry, hindi ko na mind. Doc, pwede kami umaro at PowerPoint? Yes, pwede naman. Kala ko ba may nagvi-video sa inyo? Hindi ko naman pinagdadamot yung PowerPoint ko. Kasi pare-parehas lang naman yan sa libro. At kung ang lalabas sa exam is in the PowerPoint, hindi, yay, nakasagot kayo. Kung hindi nakasagot, sorry. What else? Doc, reversible po ba heratanan? I would say, let us hope and pray. Of course, reversible naman lahat. Otherwise, kung magkaroon ka ng SVT tas irreversible niya, prognosis is bad. Ma'am, nag-SVT kayo, irreversible and you will die in 10, 9, 8, 7, ganun. So, reversible lahat, nagagawa namin ng paraan. Ma-appreciate mo siya if you become a physician na. Pag nagpa-practice ka na, you will save lives. Okay, sometimes it's just a single lead, like lead 2. Sometimes it will be a complete complete 12 lead. But most of the time, it will just be rhythm straight. Because arrhythmia to hindi tayo Rhythm streak lang, makakadiagnose na kayo. You don't need the entire 12 leads to say this is VTAC. Di ba? Pag wide complex QRS na siya, na tachycardia, VTAC na yun. Or you see an atrial sawtooth pattern, kahit V1 lang or V2 lang, madadiagnose na yun as atrial flutter. To
Dok,
save,
include nimo ang vectorial analysis sa exam.
no. That's difficult for you. Don't read that. Sorry, you can read that if you want to increase your knowledge and wisdom. Pero hindi din siya lumalabas sa board exam eh. At saka kahit nga mga consultants, hindi rin yan alam eh.
Eyeballing na gamit.
Oo. Tanungin niyo yung mga interns kung alam nila yung vectorial knowledge. Hindi nila alam yan. Kahit nga ako, na cardiologist na ako, na-stroke pa rin ako sa vectorial analysis. So, kayo pa kaya? Ay, hindi ko yan sinama. Doc, pwede po ba kami gumamit yung calculator? Pwede naman. Kung ayaw mo mag-eyeballing, nahirapan kang mag-memorize ng 300, 150, 175, 60, 50, 40, 30, 20. Go, mag-calculator ka. Just make sure you count the small number of small squares and then 1/5 divided by these small squares. That's the heart rate of the patient. In an entire ECG, doc, which lead is best to look at the diagnosis of arrhythmia? Lead 2. Because lead 2, ang victor kasi ng SE node at saka halos lahat ng AV node, bundle of His, pa-inferiorly and to the left, which will be catched by lead 2. Exactly kung nakaharap si lead 2. Kaya it will be towards lead 2. So kung ano mang rhythm niya, it will be catched by lead 2. Kaya I would say lead 2, inferior lead. Not V2, but lead 2. Kasi ang V1, V2, V3, V4, we put V when we pronounce it. But ang lead 1, lead 2, lead 3, hindi mo naman pwedeng sabihin lead V1. We just say lead 1, lead 2, lead 3. Not inferior leads. Yes, you are correct. Correct. Lead 2. 2-3 EVF is an inferior lead.
Doc, and management, Doc, gini-include mo exam?
No. This is physiology. Parang, I just said the management to help. Para lang maintindihan nyo, we do something. Pero hindi pa. Gusto mong isali?
Wag na, Doc.
Hindi naman natin na-discuss ng maayos, kaya wag na lang.
Dok, mga pera ka items set mo iga-exam.
Parang buong akin ata for this bi-monthly. I have to check. Kasi parang ako lahat ang nag-lecture until end of November. Parang ganun. Buong cardio kasi sa akin. So, good luck.
Multiple choice po ba?
Multiple choice. Depende sa mood ko. Baka bukas identification.
Ah,
Mahirap mag-check sa pag hindi multiple choice.
Sige, Dok, multiple choice na lang, Dok.
What is left axis deviation? It's the axis is more than 30 degrees. Sa ibang book kasi 15. Sa ibang book 30. Kaya let's set at ano bang sinabi ko sa inyo? Don't worry if I show an exam. Hindi lalabas ng left axis deviation anyway. But left axis deviation meaning that the axis, the one chamber has dilated. Let's say the left ventricle has dilated so much that the entire vector, instead na paganon, inferiorly and to the left, mas inferiorly and a little bit more to the left. Kaya yung entire vector niyan, the axis is moved towards, let's say, 45 degrees. That's left axis deviation. Now, right axis deviation naman, the right ventricle has dilated or has enlarged so much to the point na ma-override niya yung axis ng left ventricle. And so, when the entire vector will move to the right, more than 115, ang cutoff natin, anong sinabi ko sa inyo, 100 pa? If it is increased more than 120, the right axis deviation na yun. Yun yung concept, yung nakakatulong sa amin as cardiologists and as clinicians. If the axis is deviated to the right, nag-iisip kami, baka malaki yung right ventricle. Or if that is deviated to the left, dilated yung LV. Yun lang yung nakakatulong sa amin. And so, kakapain mo yung chest kung may heave, RV heave, or kung whatever apex beat is displaced to the left, it will correlate your ECG. May left axis deviation, the apex beat is deviated to the left, then nadadagdagan yung assessment sa patient. I hope nasagot ko yun, Makamay. Cindy.
Doc, kuan Doc ba, V3, negative ba or positive? Wala kasi mention habok.
Okay. So, V1, V2, transition kasi ang V3, V3 and V4, transition siya. So, V1, V2, kanina may nag-question kasi about bakit daw may Q-wave, bakit yung iba wala. So, kung na-discuss natin yung vectorial analysis, pag sa AV node, pag conduct to the bundle of V's, the first that will be depolarized will be the septum. So the vector will move towards the septum, which is towards V1, V2, and that's why there will be an R wave. Kasi towards the V1, it will the pen will move upwards, diba? If the vector or the electrical impulse is towards the lead, the pen will move upwards. So kaya it will produce an R wave kasi towards the V1, V2. But that is away from V5, V6 kasi si V5, V6 diba nandito sa my lateral. So it's away from V5, V6. That's why there will be a Q wave on V5, V6, right? And then once the septum is depolarized, it will depolarize the inferior wall of the ventricles. Kaya bababa naman towards V3, V4. So tataas si V3, V4. It will produce an R wave in V3, V4 na mataas. And then the last impulse will now move towards superiorly kasi di ba pag ganun siya. So superiorly, which will be towards now to towards to V5, V6. Kaya matataas naman ang R wave in V5, V6 on the last part. So, meron kang transition na R wave, V5, V1, V2, V3, pataas ng pataas yung R wave hanggang V5, V6, sobrang taas ng R wave. So, si V5, V6, initially may konting Q wave and then R na napakalaki. Si V1 naman is initially na mas small R wave and then pababa na S wave. Kasi 'di ba sa last part ng electrical impulse it moves towards V5, V6 which is away from V1, V2 kaya S wave ang predominant kay V5, V1, V2. Naintindihan niyo ba 'yon? Or jargon anyway. That's the beauty of understanding an ECG in a vectorial analysis. Kasi pag tinitingnan mo yung ECG, iintindihin mo galing ba saan siya pumasok sa AV node, bundle of V's, parang ganun. So, pag nag-a-analyze ka sa ECG, maganda sana kung may knowledge ka sa vectorial analysis. Pero, hindi naman siya pinag-aaralan in-depth ng lahat ng doktor. So, trabaho na yan ng mga cardiologists to do that. Kaya, hindi rin natin diniscuss yung chapter na yun. Napakahirap nun. May stroke kayo nun.
Tok S-wave ngayon na to, direto hiya negative deflection and R-wave and V1, V2.
V1, V2 initially will produce an R wave and then after that S wave. So hindi siya Q wave, S wave. Ang definition natin ng Q wave is from the isoelectric line. If it went down below the isoelectric line, that's a Q wave. And then if it goes up from the isoelectric line, that's an R wave. And then from the R wave, if it will go down again below the isoelectric line, that's an S wave. So for example, isoelectric line, it went down and then up and then above the isoelectric line, up, and then it went down, but only up to the isoelectric line and then nag-T wave ka. Then you only have a Q and an R wave, but that is still called as QRS complex. Kahit walang S, it is called as a QRS complex. So in every QRS complex, it doesn't mean that the three waves is always present. There can be just a Q and an R wave, or even an R wave and an S wave, but walang Q. And sometimes it's just a Q wave, walang R, walang S. So, but it is still called as a QRS complex. Mahirap no yung terminology.
Oo, Dok.
Sorry, may mga terminology tayo.
And kuan kasi, Dok, again mention lahabok, Dok, and V1, V2 is going down